one of our very exciting most exciting sessions of the symposium, in that one of our main goals as the APS Type 1 Foundation is to find our patients. We, as patients and families, know the struggle of getting a diagnosis and the long years of worry and suffering, and I think unnecessary suffering, that occurs before a diagnosis is made, because there's such great potential for management now once we have that diagnosis. So this panel is going to speak about this important topic of how we find and diagnose these patients. So I have with me on my left, as you know, Dr. Eystein Husebye, who's joined us from the University of Bergen and Haukeland in Norway. Then we have Dr. Olle Kämpe, who's come to us from Stockholm in Sweden. And to his left, Dr. Mark Anderson from UCSF. And then, last but not least, Dr. Michail Lionakis from the NIH. And it's going to be somewhat of a joint project on this panel. So thank you very much.
Well, thank you. We have decided to introduce with some examples of how to find patients, and Olle and myself will present some slides, and then Michail and Mark and all four of us will join the discussion with you. So first, this is what we discussed on the phone conference recently. Screening criteria suggested by the APS-1 group. So we divided this into confirmed APS-1, which is not very controversial. We have the clinical diagnosis if you have two of the three main components: mucocutaneous candidiasis, primary adrenal insufficiency or Addison's disease, or hypoparathyroidism. That's one of the criteria. The other, if you have a confirmed ER mutation, or that is two ER mutations. But then the interesting group is those with a possible APS-1. And the criteria we decided on, and that will be open for discussion today, is first hypoparathyroidism, and the recent paper published that Mark at least was co-author on, and maybe more of you, showed that if you investigate the population of isolated hypoparathyroidism, you will find APS-1 patients. We have the same experience also. Also, a first-degree family member should actually, our experience is that siblings should be tested always. And then if you have at least one of the following conditions arising before the age of 20. So this is our list of manifestations seen in APS-1. Why did we pick these? Well, many of these are either serious or they develop early in life. So I think they, in that regard, are good screening criteria. And these are chronic mucocutaneous candidiasis, primary adrenal insufficiency, animal hypoplasia, which develops early, pneumonitis that we heard of yesterday, autoimmune hepatitis is also a manifestation that often starts before the age of 12, keratoconjunctivitis, photophobia is also seen quite early, and the severe fat malabsorption or malabsorption. We might add some other components that will be open for discussion. So just an example, this is a rather old paper. We screened our Addison registry, looking at those who had got Addison's disease before the age of 20. That was one criteria. The other was APS-1 autoantibodies that were quite specific for APS-1. Those listed there is AADC, aromatic amino acid decarboxylase, or DOPA decarboxylase. It's an enzyme participating in the synthesis of adrenaline or adrenaline, these stress hormones. Side chain cleavage enzyme makes the steroids in the adrenals and the ovaries, in testes. And also 17-hydroxylase is also a steroid enzyme. And all other suspect manifestations of APS1, like early alopecia and so on. But to make a long story short, we found one new APS1 patient. He was then aged 30. He was homozygous for the North American, UK, Norwegian mutation, if we can call it that. He got Addison when he was 12. He had no other manifestation at the time, not even enamel hypoplasia. But his older sister had died at 4 in a varicella infection. I talked to the mother, and this child was very dark-skinned, kind of hyperpigmented, so it might have been an adrenal crisis. Later, when the interferon antibodies came along, he was positive for that, and also IL-22, but not before age 42 at the Christmas party. He got a big chunk of meat that fastened in his esophagus, and then we saw that he had candidiasis in the esophagus. Also, this patient, we get sometimes hypopara patients referred from the pediatrician. This young girl had idiopathic hypoparathyroidism from 2 years of age. She was managed at Alpha at 18. She was referred to us, and my colleague started to do a workup. He wanted to find out what was the reason for the hypopara. So he ran a test for DiGeorge that was normal. He did sequencing of the calcium sensing receptor protein. It's kind of the protein that monitors calcium levels in the blood, and that was also normal. Then we ran the interferon antibody assay that came along at that time, and then it was positive. And she also was homozygous for this ER mutation. It turned out that she had interferon omega antibodies, and also the NALP5 autoantibody was positive, which is associated with hypoparathyroidism. She then was sent to the dentist, or actually my colleagues looked and saw that she had signs of enamel hypoplasia. She later developed an opticus nevritis, which was described as it was different from the one you see in MS. Mm-hmm. She didn't lose this color sensation, so it was. And they also talked about maybe that it wasn't a retinopathy. We've only seen the patient records. But we see that in APS1, and Mark has studied, looked at autoantigens and retinopathy in APS1. Then she got hypothyroidism, and she self-diagnosed. Actually, she's a physician, so as an intern, she thought she was a bit tired and the skin was a bit dark, and she ran the test herself, or not, she sent blood herself to the lab and diagnosed Addison's disease. And 3 years earlier, we had screened the 21-hydroxylase. It was negative, but unfortunately, we didn't have any blood tests between the 2 time points, but at diagnosis, it was clearly positive. We'll come back to that. Finally, this had a young guy had autoimmune hepatitis. He was put on steroids, malabsorption, and then a colleague, my former PhD student who did a thesis on APS1, was called and discovered oral candida. The other doctors thought it was because of the prednisolone treatment that he had this recurrent candida, but then it turned out to have APS1 and also the same mutation. He then developed Addison's disease and had 21-hydroxylase antibodies also, and a number of other antibodies. So how should we diagnose these? And I will now let Olle talk a little bit about screening and how you can use screening to identify patients.
Okay, thank you. I previously told you about the Swedish Addison registry that now has more than 900 patients. So we did this study where we only had 600 patients, so 2/3 of what we have today. And Eystein and I are talking about merging the Swedish and Norwegian registries, and we will come up to 2,000 very soon. Anyway, so when we run then our registry, in the registry we have also APS1 patients, and we're running them for antibodies against interferon alpha 4. So we have done 4 patients which have, of the 6 with in the Addison cohort that has autoantibodies, that were actually unknown APS1 patients that we detected by this screening. And then we have 2 patients with Addison's disease and interferon antibodies, at least one with very high titer. So these 2 are regular Addison patients with interferon antibodies, and we don't quite understand the relevance of that. Looking for IL-22, we see the same. And we have 2 of them that are Addison patients that have IL-22 antibodies but are not APS1 patients. All these patients were air sequenced. And what we can see then is that the patients that the 4 new APS1 patients we detected, they have these antibodies very early, whereas the non-APS1, this funny Addison patient, come much later. We still have to understand the significance of this. The question is, both Eystein and I have a few patients, or rather more than a few patients with APS1 who have had elderly siblings, where you in retrospect can say that they did have an undiagnosed APS1 that they died in. And since it's a recessive disorder and siblings only has 1 in 4, you understand that there must be quite a few patients who die with this disorder undiagnosed. So in Sweden, we screen all children at birth with neonatal screening for 24 rare monogenetic diseases. And of those 100,000 births, there is only 80 to 100 children that are diagnosed every year. The majority of them have hypothyroidism or PKU. So for the rest of the 22 monogenic diseases, you find 0, 1, or 2. But it's still worth doing that. And then we have a feeling that APS1 is lost at a much higher rate. So the question is whether you should introduce compulsory testing. So in Sweden, we have this system that every child goes to see a midwife or a nurse at, I think, 2, 6, 9, and 12 months. And at one of those visits, it could be easy to take a small prick test and test for interferon antibodies. So we are discussing whether we should see if we can get funding to do a pilot in Sweden, Norway, Finland, to see how many of these patients we will find. And I think it's not only that we will avoid unnecessary death, but also to get the diagnosis much, much quicker may help patients, possibly even to avoid further complications by getting treatment early. So the workup is probably for you.
Switch just to continue on I had this screening criteria started with. So what do you do if you have one patient with some of these criteria? We think, based on the literature and our experience that the first step should be to screen for interferon antibodies, being either alpha or omega. It doesn't matter so much, maybe both of them even. But they tend to be positive in almost all patients. And if they are positive, we go on to sequence the AIR gene. So that's kind of the two main steps. First, a screening step with interferon antibodies, and then go on to sequencing. Then I won't go into the whole chart, but just to highlight those 2 points. But that's only one simple test. But Olle has some ideas on maybe how we could do this more effectively in the future.
I don't know. It's not really new. I mean, we heard of it the last by Dr. Robinson talking about making your own arrays. It's quite simple nowadays. It's like a jet ink printer, and you can print almost anything on a slide. So it looks like this. We take all the autoantigens and a few other things, and then we put it on arrays. So we have focused arrays. So on one slide here, we have 21, which has the same. So we can, in this setting, but we can do it much more efficiently, obviously, test 21 serum samples for 40 different autoantigens. And that will mean that instead of you sending sera to Sweden, waiting half a year to get the results, and we're doing the test one by one in a rather cumbersome way, we can send out these arrays, and you can test 1, 2, or more patients and do it within a day. So just to show that it works for interferon, you have a good correlation with the protarray, almost linear. We can use it for quite a few antigens, and it works beautifully. We can use it in a way to see what kind of antibody profile they have. So you can see these 2 patients are different, and that gives clinical information. The 3rd patient. So what about mass screening then? If we want to screen 100,000 serum samples, we could possibly do the reverse, to print the serum from patients. So print 10,000 sera on one single slide, and then probe with interferon instead, or IL-22. But there are other ways to do this multiplex testing, of course. So I leave that to Eystein. That's probably the same.
So that's the same slide as we started with, and I guess we'll open up for questions and comments from both the panels and the audience.
Yeah.
So.
I'm just going to re-emphasize a couple of points here for the diagnosis of APS1. So what's changed in the last 10 to 15 years? And so a couple of key things, of course. So the first is the gene being identified, and you can do the genetic testing. The second thing are these amazing antibodies that Adrian talked about, right? These type 1 interferon autoantibodies are not really seen anywhere clinically outside of APS1 for the most part. Mm-hmm. And so a great thing about these antibodies is that they're actually easy to detect in the laboratory. You can get a quick turnaround of doing the test once the laboratory is set up for it. And so the flow chart the busy flow chart that you saw a minute ago, we came around to putting that flow chart together because, again, the antibodies, easy to detect, can be quickly detected, and they're very specific, right? So the chance that somebody's positive for one of those antibodies and they don't have APS1 is relatively low. And so it just makes things move more quickly in figuring out whether somebody has APS1 or not. And so in my experience, a typical thing that I'll get is there'll invariably be an email in my email box from a physician somewhere in the United States that has a patient, and then we'll tell them to send the serum to our lab. We check the interferon antibodies. If they're positive, then the ball gets rolling relatively quickly. So another important point to make about the diagnosis and the diagnostic odyssey that I know many people in the room have experienced already is our healthcare system versus the healthcare system that exists in Scandinavia are completely different beasts, right? And so I think that there are lessons to be learned there. I don't know if we want to have a discussion about that, but how patients get funneled in America can be I think it can be very difficult.
And I just, on behalf of the patients and families, one of the issues that Robin Finch and I keep talking about is how logistically is this going to work, in particular for our American patients who aren't near a research center.
That's right.
So somehow we are going to figure this out, but I don't know if you want to speak to the possibilities of how this could work briefly for patients to get these antibody testing and genetic testing when they don't have insurance coverage and they don't live in San Francisco or Bethesda.
That's right. So for antibody testing and for genetic testing, I think Eystein can provide the genetic testing and I can provide autoantibody testing for free. And it's quite easy. I will be sending some of you the kind of package that we send out in Sweden. So we have an envelope that is pre-packed with patient information, patient consent form, the tubes you should use, an extra tube to put the serum in, transport tubes to put the tubes in, and envelope that has already stamps and the right address on.
And does the lab actually have to do anything other than draw the blood?
Yes, it has to separate the blood cells from the serum. Otherwise, we will have too much hemolysis when it arrives to us. But it can be sent at ambient temperature, nothing to freeze, no. So it's quite easy, actually.
Should we explore the possibility of only bleeding blood on a filter paper? Send it in.
Oh, that could be, but what about the
for
sequencing?
Even the sequence. We could test it out. That would make things easy. But
Yeah, there's some challenges too, though. So in America, you can't do genetic testing without genetic counseling and have it CLIA approved, right? And Michail, you back me up on that.
Absolutely.
Right. So just because we can send you the genetic test doesn't mean that a doctor can interpret it without genetic counseling.
In the medical record.
Right. The antibody you could do.
Okay.
Right, and then that could come back. But anytime you're doing genetic testing, you need genetic counseling involved.
Before or after?
For insurance to pay for it, for a doctor to interpret the result. So this is one of the challenges that we're getting at right now. Is see how things are different between our
insurance is
two
not
countries.
paying for it.
But
And
you won't need
interpretation they can get
insurance.
from us.
Yeah, they can get in.
But I guess the counseling is, you have to counsel them beforehand to explain
Yep.
the
The risks and the
possibilities,
benefits. Yes.
what the result can be. What is the implication of a
Yep.
negative, of a positive result for you and your family?
Well, the implication is you get a diagnosis, right?
Yeah.
I'm not sure. I quite.
That's in
We must have a
general.
very different approach in Sweden to.
I think we do. So I think we have some work to figure out how it's all going to
But,
translate to Americans.
A potential way around that is if there is autoantibody screening in a bigger group of people, and then it becomes that among those 100 people you have 15 that have a very specific autoantibody, then that might be a second phase of proceeding with the genetic testing after having the autoantibody
But
result.
you can get the sample
Yes, absolutely.
and put in the freezer then.
So
Okay.
Yeah. I think, may I just make a comment
Of course.
for Olle, because I see that you are having a hard time understanding. Canada has the same approach, and I've been very involved in screening for congenital hypothyroidism and for considering the pros and cons of screening, for instance, for congenital adrenal hyperplasia, which is another cause of primary adrenal failure. And the reason we are so now insisting on counseling prior to actually doing a genetic test is because even if the test comes back negative, that is, the disease is not confirmed, the psychological impact on those families that have been screened cannot be underestimated. And so I think it's an attempt to protect the majority who will be screened negative.
Vikings might have a different approach to questions like this, but when it comes to, do you do CH neonatal test in Canada or not?
We do, but it's
Yeah.
province-specific.
Yeah.
And interestingly, and the reason is because when we looked at the cost-benefit, I mean, there's a whole set of criteria for neonatal screening, right? You have to be able to treat the disease. The cost has to be less with screening than not screening. The impact on lifespan, et cetera. The thing about CAH is when we're following it really closely, and we have a ratio of males to females 50-50. And of course, the ones you're trying to prevent losing are the undiagnosed males, because they're
Yes.
not picked up because of ambiguous genitalia.
Yeah, so we're not so emotional about things like this in Sweden. So just CAH is a very good example, because then neonatal testing was introduced in Sweden in 1986. The gender ratio before that was 2-1, and the gender ratio afterwards was 1-1. That means that before the neonatal testing, every second male child died undiagnosed. And then you might be emotional to genetic testing or not, but I think there are loads of things to say that this is just another test. I mean, you can be... Do you do counseling before you test the blood glucose in this country? No. But that has severe implications.
I just want to say it's a very similar situation in Britain where there has to be intensive counselling. It's the same. But I just wanted actually to make another point, which will be very obvious to this panel, but I think to open this more broadly, one of the themes has been the connection of APS1 with the larger group of rare pathologies, and because of things like the 100,000 Genome Project, we will very soon have a whole series of genes that people will be putting pressure on for testing, where there's a heterogeneous clinical presentation. And I think the good news there, therefore, is that this will be an issue that the APS1 community won't have to solve in and of itself. There will be a lot of communities working on getting this sorted out. And I think that's another example which we heard about on Thursday night of collective pressure is going to help the APS1 community sort this out.
So for genetic testing, doing this now for a few years at NIH and having a lot of experience with other groups there is very particular language that goes to consents. You need to have counseling, and it's for a good reason. You know, if you do just Sanger sequencing and you don't look at deletions and you come back to a family and say you don't have potentially APS1, and then 5 years later there is a problem with the sequencing. So there are reasons for, not for this specific indication, but for overall to protect the families from both the emotional but also from mistakes that happen and other things. So insurance, which is a major impact.
We are universal healthcare, but we still have insurance companies that are breathing down everybody's neck.
So a potential resolution of that, or a potential solution of that, would be that the patients would be enrolled through the registry. They can have autoantibody screening in your labs with those specific criteria that are there, of which then there will be prime candidates for genetic testing. At that time, perhaps what might be a resolution would be that they can be enrolled in our IRB-approved protocol. We have MTAs with Olle already, and that can mean that either we can do genetic testing here, or we can authorize you through that MTA to use the sample that you have from before to run.
But we can't do it before.
I don't think this is going to be feasible. I mean, we'll have to get some genetic counselors officially in this country to give us input, but I think it's going to be impossible.
What about if they enrolled in a study?
Yeah, if they're enrolled in a study, which is what kind of I was alluding to, that has the very specific wording, and then there is a genetic counselor, which we will have to provide, it can be feasible. But having somebody sign a consent and have their blood sent for genetic reasons without a very, very specific understanding of that, it's not going to be feasible in the US. In this current climate, I don't think that's going to change.
Yeah, but what you have to understand is that to take an autoantibody test or take any blood test can have greater implications than this genetic test.
Absolutely.
It's, you know, it's a scale.
We're not-
and if you take your weight
we're not arguing
and
here.
you calculate your BMI, you might learn much more about your risks than any genetic test.
We're not arguing with Mark here. It's more like how we can make it happen. I think, we're in a place where we need to follow some rules that we don't
think-
decide on. So
I think the decision is taken when you send for the interferon antibody test, because that's equivalent for almost all of them. It's like a genetic test.
it's really not in this kind of regulatory environment.
No,
I think
maybe
that's
not
where-
for the lawyers, but
here, yeah.
for the doctors, it's like a genetic test. If it's positive, given that you have some of these manifestations, you are bound to have APS1, so you're taking a genetic test.
Can I just ask a question about the filter paper? Have you validated that? Because to me, the filter paper would be the way to go. I think you'd get the maximum amount of participants, and certainly in a physician's office, it would be very easy to do.
We have to validate.
The other alternative is in the Nord registry, you will have to explore possibilities of through your IRB to have a consent that explicitly states that blood will be sent and examined for AR sequencing. That you'll have to figure out whether you have to hire a genetic counselor for that. I think there is a way of doing that as well. Whether it's going to be more easy or difficult, I don't know. I'm just offering potential possibilities here so that it happens not in 35 years and it doesn't happen with 3,000 paperwork. But I think
How can you do this genetic counseling? Could it be an idea if the person presses on a link, gets kind of a tutorial, answer questions, so they understand the information? Is that a way to go?
So I'm not an expert on genetic counseling, but I'm a family who has experienced genetic counseling, and it is a conversation, usually with a genetic counselor, often a social worker, a geneticist. So it's a group discussion. So I want to come back to this, but first I want someone to answer Sherry's question on whether the blot paper actually works for the genetic test.
Well, we know from other cases that it works, yes, and not only steroid hormones, but also proteins that you measure in serum.
I think it would work. It'd be a question
I think so too.
of quantity. I think it's a great idea, and
But we have to validate it for autoantibody testing. But for DNA and for measuring several things in blood, like several proteins, it works beautifully. But
Can
the
I ask
main
something
question
can I
for
ask something on the filter? So how about the purple tap tube? So when we get samples from across the country, we ask them for a purple tap tube. It's shipped overnight, room temperature. You spin it, you get plasma, you can do autoantibody testing, and then you have a pellet of cells, you can do DNA. So to avoid the possibility that, that filter, you go through the whole process and then it's like you didn't have enough DNA to sequence air. So, and that doesn't require kind of processing of serum, which we have found very difficult in this country to have. And you'll laugh at it again, but it's the reality of the insurance will not pay for that red tap tube to be spun down for 5 minutes to separate that. There is no code for that, and there's no way to do that. So.
Okay.
We can spend 3 years talking about the aspects of that we cannot resolve. I think the way to see is whether either the foundation through the Nord registry will find a way to have an IRB approved protocol that justifies a purple tap tube drawing with the criteria we discussed here that can be done for both autoantibody and genetic testing with whatever requirements the regulations require in this country. So then that can be done directly there. If that's going to be a mountain of regulatory elements, or you will need to hire 3 genetic counselors from your budget to do that, a potential way around that would be that there could be non-genetic autoantibody testing, and then you could get, I'm volunteering our services to have that come to you through an MTA that we can do. We already have one. So as opposed to spending $200,000 perhaps, if that's going to be the way to go. I think one way or another we'll have to work around the system that exists. I would say purple tap 2 would be the best way, so we don't run into 30% of those didn't give you enough to do the more autoantibodies, or you needed a little bit more plasma, or we didn't have enough DNA quality or quantity.
Upstream, oh, sorry.
Go ahead, Dana.
Thank you. Just thinking about this, upstream of the genetic counseling and genetic testing, Mark, you mentioned CLIA, or the Clinical Laboratory Information Act. Now, that would also apply for the serum testing for the antibodies. And I'm not sure how that works internationally. Does it mean if somebody's doing a research assay in Sweden, does it CLIA not apply?
Can I say something on that? I don't think we have to worry about that. I think the purpose of early screening is to identify people who are at risk. After we have those 25 people, then we will have to streamline them through a CLIA certified approach that is CLIA certified in this country.
Yeah, but we would be returning a research result.
Yeah, so I don't know that this can go into the medical record, but then through the foundation and how we are involved here, then I think we might have to do that in a CLIA certified manner here.
Right.
Meaning we might have to repeat the genetic testing here, and we can do that. But I think the purpose that might be extra work, but I think the purpose of doing screening is to find those people that are affected early, and then we can worry about the CLIA aspect. It's a great question, but we can, I think, worry about that.
Another thing we
And then I'm going to sum up this
Sorry.
part.
Okay.
So last word on this section,
No.
Olle. I just want to summarize what has just gone on, because this is obviously more complicated than we think at first glance, and we're talking across oceans here and using incredible resources that are being made available to our patients and potential patients. But just to summarize, if someone is suspected as possibly having APS type 1, they can have their blood drawn. It has to be at probably a clinical center that can do some first spinning of the blood, send the kit to Ulle's lab. If he gets a result that there is anti-interferon antibodies, then we engage the NIH for the next steps, which would involve genetic counseling and the genetic testing for the AIR gene. Is that a very basic summary of what we're talking about?
I think an important first point is to figure out whether through your IRB, you can get language that includes everything.
Okay.
That is the best case scenario, I think, where so we don't go back and forth and go back a year later and say, let's amend the program. We've been there, we're doing it 10 times a year, and it's a pain. So I would say the first thing would be inquire with your IRB, what would it take in this NORD registry to have the possibility of getting a blood tube for autoantibody and genetic testing for research. There are ways to do that. I'm not familiar with this IRB, so I cannot speak for it, but I think that would be the best way to proceed. They might tell you that it requires things that you as a foundation find difficult to do, or it's feasible. And I think if it is feasible, then an avenue of what we were discussing, I would go with the purple tap tube in that case, because that will give you other means. And then that could be sent to the labs, and then what we will be doing as we'll be regrouping and discussing those cases, and then if we will have to probably have CLIA certified Sanger sequencing, which we can do at the NIH to confirm, and we'll see the patients also at the end. So that's one way of doing that.
Another way of doing it, I just want to throw it out there, is for the NORD IRB to consent patients to be contacted by other investigators. And if patients pass this screen, then we pass their name, we do something where we connect you and the patient, and then we don't have to deal with worrying about coordinating the blood and whether the research result is CLIA certified and clinically actionable or not. And then the NORD registry really just becomes an online database of patient information that's consented, but then we would remove ourselves from the blood draw and let you guys deal with that.
And then we can have a biobank in Sweden on the Swedish, legislation. But
we need to include Rhonda in this discussion too.
Oh,
we have
sorry.
a great resource here from Rockefeller University.
Hi, thank you. This is just a minor point. If you can go with the purple top and not have to have serum spun, then you don't necessarily have to go to a more sophisticated clinical center. You can have your blood drawn at Quest or by the visiting nurse or whomever. So it makes it much more accessible.
That would be
Okay.
ideal.
And you can always convert to serum from plasma. So yeah.
Okay, excellent. That's a big step for especially our patients who aren't in large urban centers. That would be huge. So we've talked about the logistics of how we do this testing, and we have these ways of confirming APS type 1 and some criteria to look at the people who possibly have APS type 1. But I wanted to spend 5 minutes, and then I'm going to open it up for questions to everyone, on how are we going to find those possible APS type 1 cases. We've heard many people talk about their experiences over the past few days of going years with these symptoms and doctors not clicking, right? That this should be on their radar. So from your perspective, what's your advice on how we reach the doctors and the patients in their own communities? I'm picking your brains.
Jerry wants to say something.
Okay, and your brains, yeah.
I would just immediately make sure that for the large association meetings, the annual meetings, that you have a booth and you make this information available. You're going to mainly get perhaps nurse clinicians and physicians, but you could start with the Endocrine Society and you could start with the European Society of Endocrinology. You're probably already doing that. And I think that would give you an idea of how many you get through that before you go through more general family physician organizations, which I think would be a bit more difficult to deal with.
A strategy that has been used at NIH, not for APS1 only, but throughout for recruitment of patients, and we're talking about rare diseases that might be out there in pockets, and is actually eliciting and sending letters to physicians, notifying that there is a NORD registry about APS1, and that I would think that would be a way to do that. There are hundreds and hundreds of letters, but that actually has been fruitful, and you can do that for endocrinologists, you can do it for hepatologists, you can do it for gastroenterologists that saw that fat malabsorption, and you might be able to get patients like that, to at least make them aware of the registry. And
just what about medical schools? Can one sponsor an exam question before you graduate? But seriously, I mean, isn't that the mill, the original source?
it is there, yeah.
Yeah, I can confirm it is on the board exam. The other, just as this is more entertainment value than anything else, is I had to renew my endocrine board about 3 years ago, and they had an APS1 error question on it. There was no correct answer. So I don't know if I got it right or wrong.
We have to make T-shirts. We have to make T-shirts that say none of the above. On
right,
them.
exactly. But I think one thing that's I wanted to come back to too again is like one of the I just share in the frustration of how the American healthcare system works. Right, we have this subspecialization, and we have a lack of physicians that can put the whole patient picture together. And I don't have a great solution for that. It's easy for the cardiologist only to think about the heart, or the gastroenterologist thinking about doing a scope procedure. And so we have a lot of that in America. I do think one thing that's fortunate is endocrinology in general is one of these specialties where the endocrinologists are have the perspective of thinking of the whole body physiology. And it does turn out that many of the manifestations of APS1 have endocrine connections. So some patients are fortunate to get in the hands of a pediatric endocrinologist or an adult endocrinologist that's saying, wait a minute, let's put this all together. But sometimes when people get just the skin manifestation or the eye manifestation, it may not come to the thinking of the doctor. And I don't have a great solution for it other than your kid better than anybody else, right? Or your relative better than anybody else. And if things aren't fitting, right, go get a second opinion. Send out emails, phone calls. I actually think the website for the foundation is going to be a great resource, not just for patients but for clinicians.
right? Like how people can get connected.
Thank you. So we have 10 minutes, and I want to run through a bunch of different voices here in the crowd. So Todd, go ahead.
Yeah, and I'm hoping that, when we move into the next session, we can potentially
do more.
continue this discussion. I will tell you that we get a lot of questions and a lot of people that contact us that just in the initial conversations you realize most likely do not have APS-1 because you're hearing a lot of APS-2 and just what they're communicating. They're very frustrated. And also the testing itself, the cost associated with that, specifically in the U.S., to get to the actual diagnosis. I'm hoping we can kind of talk about that and how the foundation could potentially support that process in the future, because there's a lot of frustration and a lot of those calls that come in sometimes get to me for the most part on the foundation side, and we channel them out where we can, but I think this is still an area that we do not have real clear direction or guidance that we need to develop.
Yes. Did I see a question in the middle? Gloria, and then Rhonda, did you? Yeah. Oh, and then I'll move to my left here.
I mean,
Okay.
More like a question, it's like a comment. We are from South America, and we listen to you, the European and the North American and the Canadian, and it's kind of frustrating and sad for us, because it's like, I mean, if you have such amount of problems, just think about us. Mm-hmm. And one thing is like what we've done is like we have like a huge family, and Pablo is 22 years old now, and when he was diagnosed or pre-diagnosed, when he began having problems, everyone looked at us as crazy people. Oh, you're a crazy mom. You're making him sick. So now that we have, my husband has nephews and nieces who are having children, I keep talking to them. Because I don't know, I mean, I don't want them to have or suffer what we've been suffering. And also, I am trying to contact Pablo's doctors back in Colombia or back in Caracas and try to tell them, like, you saw something and you helped us. And if you see anything like this in your, office, pay attention to this, because it's like we began with a rash, and the hepatitis and everything, and it's like, even though Pablo was diagnosed kind of early, even in Colombia, because one doctor in an ER felt strange that 2-year-old was having this tetany so hard, and he yelled at another doctor, like, test the calcium, and they were like, calcium for a 2-year-old? Yes, do it. And then they found out, it's like, even though we as families can keep like talking about this and teaching our family and our neighbors and people around that anything that looks strange to a mom or to a family member can be a sign of something different and that can be worked out. So
that's so
that's
important.
Just like a comment.
Thank you. Thank you. Rhonda, and then on this side.
I just wanted to follow up the comment about disseminating information to specialty organizations in meetings. I think there's probably a place for review articles that go into, general pediatrics journals, a presence at general pediatrics meetings, in residence journals like archives of whatever, family practice, pediatrics, just to raise awareness about the constellation and the disorder.
Thank you. Yes.
You have a genetic condition that has many unusual manifestations, and even though I'm a pediatric endocrinologist for a long time, it wasn't until yesterday that I knew that pneumonitis was one of these manifestations, so thank you for that. There are databases that help physicians to put unusual disease combinations together into a unifying disease. OMEM is one of them, Online Inheritance of Man. And I think that it might be of use to see if you could link somehow. Your website might link with OMEM for certain conditions that pop up. I don't know, for example, if you put in pneumonitis and hypoparathyroidism into OMEM, whether you would come up with APS-1 as a possibility, but you might, and maybe there could be a link there as well.
I do wonder how many people are diagnosed by Google that way. I know that doctors often poo-poo Google, but for rare disease patients, it is incredibly important.
So
Yes.
just a quick comment on that. I mean, this is, thinking about the future in a place like UCSF. It's been working on a collaboration with Google. I think we are entering an era where, we have the electronic medical record now finally in America sort of pervasive. There is going to be this machine-based learning and artificial intelligence that is applied to clinical charts. And perhaps that might improve diagnostics in saying this might be an APS1 patient. But one of the technical details, to me, I'm optimistic, but one of the technical details right now is the electronic medical record in America is set up around billing, right? So it has billing codes for various diseases, and so people may get misclassified with the billing code. So there's some granular problems that we also have to advocate for to improve our accuracy.
And to be able to do searches by billing codes that are relevant. So Eystein and Olle.
Just a comment. Would it be an idea to maybe work together with the Addison patient organization, the hypopara patient organization? Because it's overlapping interests, and you might reach a broader audience.
For sure, we need to work with them. I don't want to get swallowed by them personally, because our patients have such a wide array of issues, but for sure we need to work as partners with these organizations. Olle, and then we'll move down to yes. Go ahead.
Okay, so I think you have to do something very radical, because we're a bit concerned that APS1 is so rare in the States. We don't think that's the case, that you are the odd one out when it comes to prevalence. So I think quite a lot is missed here, and my question is whether all children go to dentists in the US as they do in Sweden. They do. Well, in that case, maybe dentist is where you should try and get them to recognize this enamel hypoplasia, because just like interferon alpha autoantibodies, almost all patients have this problem. Could it be a way to...
And we've talked about, as a foundation, going and speaking at dental conferences, in particular pediatric dental conferences, as a way of raising... No?
No,
okay.
No, because it's the permanent teeth that will have the biggest problems.
Yeah. No, but the baby teeth also...
Yeah. The majority of patients only have in their permanent.
Michail, is that what you've seen too?
There are ways to, again, disseminate information, and we can discuss about how this is done.
Can we move?
Yeah, absolutely. I mean, we published that last year, that it happens early on, yeah.
I just wanted to share my experience with Amrita and her sister Nisha. We saw pediatric dermatologists, we saw dentists, her pediatrician, her everyday pediatrician was an endocrinologist, and she still didn't get diagnosed until she was 7. So there's definitely a lack of awareness, and I think the review article idea in General Pediatrics journal would be a great thing, but also all of these specialties, whether it's GI or dentistry or dermatology. Yeah, emergency medicine. I don't know if there's a review article that you can publish in every single one of these journals, but I really think that's the way to go.
Pat, and then I'm going to close it with Olle.
As someone, in our profession, we research using words, right? I noticed those 2 historic articles that you guys posted yesterday, the one from 1942 and the one from... There wasn't a word on the title that I recognized. And so if some schmo is researching the way we do, looking for candidiasis, that thing ain't going to pop up, right? Because it's not in the title. So I think there's a real important role, if you're writing journal articles for general literature, that you use common terms and not reinvent them or tailor them because to your taste, right? Like you have to have a uniformity of language so that it's searchable.
Don't just put the anti-interferon antibody in your title, please. Add, add words that patients can find. I
think
that's
the
really
problem
important.
is not that the language is not used. I think the problem is that there is no publication that clearly says that pneumonitis happens in half of them and it happens at the age of 1. So we need to fix that. I think we need to. Olle already started the process with the Journal of Internal Medicine. They've written papers before. I think we need to revisit that as we're planning.
Thank you. I need to wrap this up, so I have one final question from.
Just a quick thought from a patient. I wonder, is there a need for a standardized, simple description of APS1 that includes such side issues as APS2A and 2B and things like this? Something that keeps it at a very simple level whereby the average GP, the average PCP, can expect to occasionally come across that.
I love that question right now because although I don't know it will be overly simple, Ulle's going to talk about the project that these gentlemen and perhaps some others are going to be engaged in with the Journal of Internal Medicine.
Yes. So a couple of years ago, Eystein and I and Jakob Herenthuber wrote an article about this disease, but now we've been commissioned by the Journal of Internal Medicine to write a consensus statement on the diagnosis, treatment and follow-up of autoimmune polyendocrine syndrome type 1 patients. And so that will be written now after the meeting, so Cherry Deal and the gentleman here and a couple of other experts will go together and write something exactly for the GP and to be published in January, hopefully next year, in Journal of Internal Medicine. And the last article we wrote has been highly cited. So I think this will be even better because so much has happened since last time.
Wonderful, and thank you so much for the future effort you're about to put into this consensus statement. I can only imagine the experience we would have had if we had that paper when our daughter was first diagnosed and could march it around to her various doctors and say, this is what we now need to do. So thank you, which is what many people will be doing. So thank you so much for that work. We're really looking forward to seeing the paper in the Journal of Internal Medicine. And thank you to the four of you for this extremely helpful panel. We have a lot of work to do all together, but we're making really good progress. Thank you very much.